Thank you for selecting my talk and also letting me know about the prize. I didn't know about this yet until just now, so try extra hard. But anyway, so yeah, I'm an assistant professor at the University of Pittsburgh, and my work is in infectious disease epidemiology and global health. And so I've worked in this field for a while, but then on data systems, and I'll show you some of this work. But then I was funded through BD2K with a KO1 award to cross-train in data science, and I'll show you some of the work that I've done with my new training skills in maturing the data systems that we were building into a more fair, compliant data system. Okay, so I'm moving this one with the... Okay, so just first in kind of a quick overview, I'll talk about our Project Tycho, which is a data system for disease surveillance data, and then an update that we recently did to version 2.0. And so our project started out as looking at making disease surveillance data more accessible and easier to use for researchers and analysts. As you can see, a lot of the data that is used in this field is in formats that are very difficult to use. And our research kind of drove us through digitization, extraction, and standardization of these data sets into an easy-to-use, standardized, harmonized data set. And we started this out with United States infectious disease surveillance data that started all the way back in 1888. And that ran all the way to the current. And at the time, we digitized and standardized everything from 1888 to 2014. And that allowed us and many others to do new analyses that could not previously be done because the data were so diverse and also in formats that could not be used. So why are we doing this? Why are we looking at infectious disease data? I think many of us know that infectious diseases and epidemics remain a threat to global health. We've had 3 major outbreaks in the last decade or so. The Ebola outbreak in West Africa in 2014, and then also very recently. Chikungunya and Zika virus in Latin America have emerged. And the big take-home message from some of these outbreaks is that we are really not well prepared to deal with them. Bill Gates here writes in the New England Journal of Medicine that an epidemic is one of the few catastrophes that could set the world back drastically, and that we need a better warning and response system. And this has not changed for the decades in the past that we've had these outbreaks. The data systems that are currently in place are still insufficient to really deal and respond to outbreaks. And so we really need a better way to move forward. And that's something that we try to address with our project. Here you can see some of the work that we've done previously going to countries in many places. You can see the archives of historical disease surveillance data in the US, in Niger, in Laos, Vietnam. Here's the Netherlands. It's not necessarily a low-income country problem. Historical disease surveillance data are notoriously badly organized. Now, more recently, of course, there are new electronic systems that are better, but it's still, we lack a lot of the standards, we lack a lot of harmonization and data sharing platforms between agencies that really limit the research and knowledge that we can generate from data sets such as these. And that is what we're trying to address here. You can see for the US data, we did a large-scale manual data entry process of going back this 125 years, getting tables such as this entered into computer format and harmonized into one database. Here, you can see what we can do with these data then. And so this is what somebody's called making these data actionable. Here you can see almost 100 years, 1928 to 2002, weekly disease surveillance data for measles, weekly incidence rates, causing a very characteristic pattern for this disease at the national level. And then in color coding for each state, I'm showing here the incidence rates. And so black means we have no data, no reports. Blue is our low incidence rates. and red are high incidence rates. And you can see, for example, for some states like Hawaii here and Alaska, but until the 50s there were no data because they weren't part of the routine notifiable federal surveillance system. But then very remarkably, the big epidemics before the 60s and then this red line is the introduction of the measles vaccine. And you can see the very dramatic decline of measles incidence after the vaccine was introduced. And so this graph, when we published this in 2013, and we did this for 7 other diseases, really triggered a great debate about and helped the advocacy for vaccination programs in the country. And it even was reproduced in 2015 by the Wall Street Journal as another feature about how vaccines can help. And so this would not have been possible if we hadn't gone back and digitized all these paper records. And so that's a great example of how we can use data that are not in an actionable format for something to create new knowledge and for good. So we made all these data publicly available through our Project Tycho data system for others to use. And so here you can see the results. This is between 2013 and 2017. We had up to 3,500 registered users of the data system, mostly academics here in blue, and then also government agencies, corporate users, and personal users as well. 7,000 downloads of data sets, 1 million API calls, and 250,000 page visit to the website. In the end, you can see here the number of people in different countries around the world. Really, people from all over the world have used this US disease surveillance data set, and resulting in 50 creative works. So we searched the internet, we searched all these PubMed and Google Scholar and all the databases to see what people have done with the data that we made available. And you can see 50 creative works by others have resulted that we could find. 18 peer-reviewed papers, 9 other papers, conference papers, preprints, 4 student theses, and 19 visualization or software programs that were built and trained using this data set. And so there's been really a great benefit of making these data available and an impact in terms of generating new knowledge and new scientific output. Here you can see an example of the scientific papers that came out by other groups than ours. Here is our first release of the database in 2013. And you can see very quickly Nature did a infographic. And then 2015, the first set of 5 or so peer-reviewed papers came out by some colleagues of ours that had used our data. And then trickling through the entire time series, new papers have been coming out. Some of them are studies on disease transmission dynamics, for which you need long time series of historical data. And then later on, you see some studies about data mining algorithms or machine learning algorithms that were not built by medical professionals or researchers, but by computer scientists that needed real-world data sets to train their algorithms. And they now train them on real-world biomedical data rather than on astronomy data, for example. And so that's been a great transition of their work into biomedicine. Now, what's new in 2.0? We added new data. We tried to keep this all updated, so we updated again the US data to 2017, but we also added dengue surveillance data from many countries around the world. And then, having been in the BD2K training for a while, I was able to make some great improvements, I think, in making the data more FAIR compliant, more findable, accessible, interoperable, and reusable. The way we did this is by grouping the data into data sets rather than one big database. Each data set could then have a DOI and could have specific metadata files associated with it. And we standardized the entire content of the data and the metadata using standard ontologies and vocabularies so that the data would be interoperable with other data sets. Just to show that getting data from countries around the world is not just a matter of sending some emails. You can see we went to all the different countries here in Southeast Asia for a specific project, 8 countries, making specific collaborations with everybody. And so building a data system like this it has a technical component to it that I'll talk about, but there's also a great human, social, cultural component of asking colleagues and partners to release data sets that have not been public yet. And so that's a process that I won't talk about, but that we did publish about. And also to show that now we have data in the system for the US. Here is countries, and here you can see the conditions, the disease conditions. The US, we had up to 92 infectious disease conditions listed here. And this is the number of data points, data observations we have per disease and country. So for the US, you see a fair amount of diseases. For all the other countries, we only have dengue-related conditions. But this worked out very nicely because having this kind of cross-section of the disease country space enables us to build a data system that now going forward, we can incorporate any condition from any country. And so we're prepared to expand, basically. You can see over time as well, the US here has the largest time period covered, and the dengue for the other countries is between the 60s and about 2010, just to give you a feel for what the content is. Now, a little bit about the problem of standards in global health. I'll show this with an extremely simplistic example, but it's very illustrative. There is a wide range of data repositories. The data are not, the problem with global health data is that it's very scattered in lots of repositories. The data are not necessarily big yet in terms of megabytes, but the diversity component is really strong. There's also almost no consensus, I would say, about what standards to use to represent the information, and metadata is extremely limited. So here is two websites, just as an illustration. The World Health Organization and the Institute of Health Metrics and Evaluation that generates the global burden of disease estimates. These are very strongly related organizations. And just looking up information about Vietnam, you can see here that this place, WHO, puts Vietnam like this, and ISMB puts it like this. And so it's a very simple example, but it's illustrative because all the data from WHO put Vietnam like this, and ISMB puts it like this. So if you're just a researcher and you're trying to merge these data sets, it doesn't work unless you do fuzzy matching and all kinds of things. So why is this? That's, you know, and I think it's not specific to global health. It's probably a problem that we see everywhere, but I really hope that we can improve by using standards, making it so that these data sets can be used more easily together. Now, so what we did in Project Tycho is we have a lot of information pieces that we try to use already widely used standards and ontologies. So for example, for the disease names, we use the SNOMED terminology and codes. For pathogens and CBI taxonomy, and so for geolocations, ISO codes and geonames, etc. So we try to find widely used ontologies and standards. Although I have to say, sometimes you can pick from many, and it's hard to pick which standard to use. But we just had to make some decisions here. Now, the standard data format, we made a standard data format for pre-compiled data sets with 20 variables. We registered at fair sharing, and also data for custom compiled format. And so every person, every download from Tycho will have exactly the same format, which we found in the past really helps users to build workflows around this that don't have to change every time they download a data set. Here you can see the variables. We have 20 variables ranging from condition names, SNOMED codes, pathogen names, pathogen codes, lots of location information, time period, and some other variables. So that will help people to use the data. The metadata, we have two formats. We have DataCite XML files for each data set, and we have the data tag suite from BioCaddy, JSON files also for each data set. And so each use slightly different terms, but roughly the same information. A DataCite, we have the title, identifier, creators, dates, geolocation, and then for the data tag suite, the same kind of information. Also the is about and the subject. We try to really use as much terms as possible to have very rich metadata. Now, then quickly a walkthrough through the website so that you can see what we've done. Here is the home page. We spent quite some time to actually build a professional looking website. That took longer than I thought, but that's a good learning point. Took 5 months with 1.5 developer full-time. So, but anyway, I'm very happy with the result. So here is 3 ways to access the data. Pre-compiled data sets, 360 data sets. for each country and condition. You can compile also your own, and there is an API. So here is a list of the pre-compiled US data sets, 92, one for each condition. So you can click on the data set and download right away. You can also see they all have a DOI. We were able through EasyEd service to actually mint DOIs for each of these data sets. 271 pre-compiled dengue data sets. So for each country, there is a data set as well for dengue-related conditions. And then each data set has a landing page, so the DOI resolves to this landing page where it shows the DOI. It shows download links for the data set itself and for each of the, the metadata files, the DATs and the XML data site metadata file. Something about the condition, and if you click on this SNOMED link, it brings you straight to the SNOMED catalog that has the definition for this condition. Same thing with the pathogen code here. So there are already links to other data systems like that, and there is a citation as well. We hope that through the citation, we'll be able to track even better what people have done with our data sets. And then there's a custom compiled interface where people can click. These are 20 variables, and people can click any direction to narrow this down to their set that they like. And there's three things you can really do with this. One is explore data content. Two is download a custom data set. And three is to visualize. So here is the explore data content. You can click on Cambodia, for example. You see how many accounts there are for Cambodia. You can see right away that there is only dengue, no other diseases. You click on an admin 1 level, and then you can see that we have what kind of age range we have, what time period, etc. So it's a very quick way to browse the data sets, content, downloading custom data. For example, click on Rocky Mountain Spotted Fever. You can see we only have this for the US. You can click 2 different states, hit download, and then you only get the data for those states in your data set, and you don't have to deal with all of the US data for this condition. So that allows you to quickly narrow things down and download. And then visualize the data. For example, for dengue here, you can click Thailand, and then once you have Thailand, you can click 3 different provinces, for example, in Thailand, and then here is the visualization that shows you, you can compare the time series of Thailand dengue data. And so this is a nice way to it's very rudimentary still, but given that we have an API, we hope that others will actually build more sophisticated visualization system, and if not, then we'll do it ourselves. So the next steps is to really expand the data, continue this so that it becomes an even more robust data resource with surveillance data, but also other variables like climate, demographic, vaccination coverage data. Of course, to connect to other biomedical data systems, because now we are standardized. Hopefully, we can connect even more closer to other data systems, and I hope that at this conference, I'll be getting great ideas of what data systems we could connect to. Also, make better use of ontologies and ontology-based reasoning. So what we have now is just use the terminology as a standard terminology. We are not using the descriptive logic built in the ontologies to reason. And I was at the tutorial yesterday about this, and there are some great ways we can actually use the logic built in the ontologies to make it even easier for people to discover and integrate the data sets. Add research data from publications. So this is from standard government reports, but we can also extract and encode information from peer-reviewed papers and link that to the surveillance data from government reports. And so that's another angle. And then to function as a repository, which means that data sets that have been prepared by others could also be listed on our repository. And so that's something we'll explore in the near future. And then, of course, the sustainable business model, because we'd like to maintain the core infrastructure and have it available for researchers in the future. And funding this from research funds is not always easy, so we want to think about some other ways to do this. I have here acknowledgements. Work with Don Burke in public health, with Mike Wagner in the, as my KO1 BD2K advisor, and a team of programmers. And I also want to say, if you want to hear more, come to the biontologies track on Tuesday. I'll talk about this some more. And here's the poster as well on Tuesday around noon. So thank you very much.
Program Officer from NIH and NIGMS. So, and the the other person is KK King, who is the BD2K Centers Coordination Center director. So we have time for like one brief question. Yes.
What's the biggest challenge for creating a consistent platform?
Great question. There are many challenges. I would say the biggest one is to standardize the information in a way that we don't make stuff up. So we try to take what the sources imply when they create the data set, and often we want to standardize, for example, assign location codes, but if the source is ambiguous about this, it's not very clear where exactly location. You really want to kind of narrow this down and put a code or something, but you shouldn't really. So that fine-tuning of standardizing this and excluding some other things that we just don't have enough information, that's a fine line. And then, as I said, picking the standards to use, whether, for example, we use SNOMED or ICD-10, those are big decisions, and we did both in the end, but that can be quite challenging as well. But yeah, happy to talk more about it.
Great.